Now I'm going to talk about using the AxGuard nerve connector in this technique that we call connector-assisted repair. And this connector-assisted repair is really meant for gaps less than 5 millimeters. And the reason why we even looked at developing a nerve connector is because when you look at the historical outcomes for direct repair, which is considered the best case scenario by many surgeons, you can see that the outcomes really aren't as good as you would expect. I mean, if a surgeon considers direct repair a best case scenario, you would think it would have, you know, the highest level of meaningful recovery. But when we look at the literature, we see that that just really doesn't seem to be true. And that can be due to a number of factors then that can affect outcomes in direct repair. So number one is inadequate resection. Number two is tension. Number three is suture irritation. And then number four is poor fascicular alignment. And then number five is this idea of neurotropism. And I'm going to describe each one of these in detail. So the first thing that we're going to talk about is inadequate resection. And so in nerve repair, this is really the first key step to obtaining good results. If scarred nerve ends are sutured back together, no matter how you repair it, direct repair, autograft, allograft, conduit, you aren't going to get good outcomes because nerve cannot regenerate through scar. Scar tissue blocks everything. And so really getting back to those healthy fascicles is the key first step. Now, this can be really difficult for surgeons because there's not a good way to determine scar in the clinic. You know, sometimes you can have a nerve, especially in a nerve that's been stretched. You know, you may have an area of visible damage, which is what you see in this picture here. You can see the gouge out of the nerve, but there is this area of scar that extends a long way in the nerve. And, you know, a surgeon doesn't have a good way to really detect that. Sometimes it's by feel. You know, scarred nerve may feel a little more woody or hard than a typical nerve. And so it is a difficult concept, but really, really key to getting a good repair. And this is a study that really demonstrates this concept. So this paper was published back in 2013, and this was a patient who had a fractured wrist with an ulnar nerve injury. And 3 months after his ORIF, he had a neuroma resection and reconstruction with a 1.7 centimeter advance. After 11 months, there wasn't any recovery. And so the surgeon decided to go back in and revise. And he took out the advance and reconstructed with a 4 centimeter autograft. Now in this paper, they attribute the failure to the allograft. But what's really interesting is that they sent the allograft and nerve that they resected for histology and printed and included the results in this paper. And so what we see here, this is from the proximal native nerve, this is from the allograft, and then this is from the distal native nerve. So let's look. This is a blow up of the picture of the proximal native nerve. And what you can see is that by far the majority of this nerve was composed of scar tissue. So really what this was not a failure of the allograft, but it was a failure to resect back to healthy tissue during the first surgery. So you can see, you know, these fascicles up here are the only ones that had any chance of regenerating. Nothing was going to grow through this whole area. And so this nerve never really had a chance to begin with. And so really, you know, there's a paper out there from 2013 that says, you know, in order to really have good outcomes, you want at least 75% preserve nerve architecture. There's not a lot that they base it on in that article, but that is their recommendation. And, you know, I just really think this drives home the point that, you really need appropriate resection in order to obtain good outcomes, no matter how you repair the nerve. So the next thing that can affect direct repair is tension at the coaptation. So in an intact nerve, an intact nerve is under tension, but that tension is distributed all along the length of the nerve. When the nerve is cut and sutured back together, the tension becomes concentrated at those suture points. And increased tension in preclinical models has shown to reduce axon regeneration. Now, why would that be? Well, it's because tension causes ischemia. So if you think of a hollow tube and you put it under tension, what happens to it? It collapses down in the middle. Well, the same thing happens to a nerve when it's put under tension. It starts to collapse down, that compresses the blood vessels. And nerves have a really high metabolic need for regeneration. So if you don't have blood flow going through that area, you're not going to have regeneration. Now, the issue here is you see 10% elongation of the nerve causes a 50% reduction in blood flow. But during a surgical procedure, there's no good way to tell how much tension is too much tension. So this can be a difficult concept. Now, the third thing that can affect regeneration is this idea of suture irritation. So nerve repair is typically performed with non-resorbable suture. And suture, that non-resorbable suture can be inflammatory. Now, it can be minor. It can cause just a small fibrous tissue layer around the suture, or some people can have a more severe reaction and they can get granulomas and fibrous tissue encapsulation of that suture. Now, if you think about that happening at the coaptation where nerves are trying to regenerate, that can actually block some of that regeneration. The next thing I'm going to talk about is fascicular alignment. So, when a surgeon is doing a direct repair, it can be very easy to over-tighten the sutures, which can then cause fascicular misalignment. So the best way to think about it is it just kind of smashes those nerve ends together a little bit. And, that causes the fascicles to sort of become misaligned. They sort of point every which way, and that causes axon growth to grow sort of in every direction. And that axon misdirection can end up causing a neuroma formation, and neuromas can end up being really painful. So this can be a really big problem. Now, the last thing I'm going to talk about is this idea of neurotropism, and this is really important for mixed nerves, so nerves that have a sensory and a motor component. And so this is a really interesting study that was done by Dr. Peter Evans. And what they did here is they took a mixed nerve and they sutured the nerve, they cut it, and they had 4 groups. So in one, they sutured the nerve together directly in its proper orientation. So the sensory fascicles sutured so that they were across from sensory fascicles on the other side. And then in group 2, what they did was they flipped it. So the sensory fascicles were now across from the motor fascicles on the distal side, and the motor fascicles on the proximal side were across from the sensory fascicles on the distal side. And then they repeated the same thing, but they used a conduit and left a small gap between the nerve ends. And so when it comes to sensory and motor axon regrowth, there are neurotrophic factors that are specific to each one. And so when they looked at the function in these animals, what they found is that groups 1, 3, and 4 all recovered back to baseline, but they saw no recovery in group 2, which had been sutured together directly in that misaligned formation. And so what they found was that even when the motor and sensory fascicles are misaligned, if you put them in a conduit and leave a small gap, the axons are able to find their way to the appropriate fascicles on the other side. So they'll actually cross, sort of diagonally, like you see depicted in the picture on the bottom. and make their way to the appropriate fascicles. So this can be a real benefit of connector-assisted repair for mixed nerve injuries. So again, with direct repair, you can very easily misalign your fascicles. You put tension at the coaptation, and you have the potential for axonal escape. With connector-assisted repair, this helps to solve a lot of those problems. So you don't have to force you don't have this forced mismatch of the fascicles. You can leave a small gap between the fascicles, or between the nerve ends, to allow the axons, to find their own way. You can move your sutures away from the coaptation to the edge of the conduit, and that does two things. It removes any potential inflammation related to those sutures away from your coaptation, and it also helps to relieve tension at that coaptation. And then having the connector-assisted repair helps to prevent infiltration from surrounding tissue, and also helps to minimize any axonal escape. And so there are lots of different variations to this technique. Some surgeons like to put a loose air knot to hold the ends together and then slide the connector over. Some like to leave a small gap between the nerve ends. And connector-assisted repair can also be utilized in graft repairs, either allograft or autograft. And there is some clinical evidence for this technique. So this paper is a meta-analysis that was done by Dr. Duchek, and they looked at 12 clinical studies, 415 subjects. And what he found is that when a person received connector-assisted repair, the positive outcomes were 83%. Compared to the suture-only repair, which was significantly lower. And what was really interesting in this study is that there was a 50% increased likelihood of pain and sensitivity at the repair site when a connector wasn't used. And that, is probably likely due to neuroma formation at that coaptation. This was, demonstrated again in another study. And in this study, they looked at nerve wrapping to help prevent pain in digital replants. And what they found is that patients who received a wrap at the coaptation during the replant had significantly lower pain scores than patients who did not. And in both of these studies, these weren't necessarily our products. They weren't necessarily the Axoguard products. It was definitely not the Axoguard product in this particular study here. But what this shows is really the usefulness of the technique. It's really how important it is to protect the coaptation, to achieve potentially better outcomes and less pain utilizing this technique. And then again, I'm sure you are all familiar with this study by now. This is the Schmidhammer study. And again, just provides some good evidence on the benefits of relieving tension with connectors. They saw less scarring, better revascularization, and better functional outcomes. Now, this is an interesting study, just a little added benefit of connector-assisted repair. This was a cadaver study that we did that looked at connector-assisted repair, conduit only, which was essentially leaving a large gap, like if you were using a conduit to repair a gap, and then direct repair. And we had experienced surgeons and we had inexperienced surgeons doing all of these techniques. And we came up with a grading scale. And then we had some blinded assessors who went around and graded the nerve repairs based on this grading scale. And what we found is that connector-assisted repair basically levels the playing field between the experienced surgeons and the inexperienced surgeons. So, when you look at how many surgeons were graded as excellent in the suture repaired, For experienced and inexperienced, you see, there weren't very many in the inexperienced group who were graded as excellent. But then when you look at the connector-assisted repair, you see that, that number increases and is much closer to the experienced surgeons than for the suture-only repair. So, it just helps inexperienced surgeons do a technically better repair. And then finally, another little added benefit of connector-assisted repair has to do with the strength of the repair. So this was a study that looked at how strong coaptations were with varying numbers of sutures, either just for direct repair or with a connector-assisted repair. And what they found was that a connector-assisted repair with 2 sutures at the edge of the conduit and either no or 2 sutures at the coaptation was just as strong as a 4-suture direct repair, but had the benefit of less sutures at the coaptation.